Hello, I'm Neil Spoof, Chair of the Sampling Interest Group. I'd like to welcome you to our live webinar today, Improving Access to Blood Tests for People with Learning Disabilities, Frequently Asked Questions, Guidance and Next Steps. Before we get on to the main part of the webinar, I'd just like to take a moment to thank our supporters and sponsors who fund this patient-centric sampling interest group, and without whom we couldn't run our webinars, which are available through our website, free to view. Just as we go on to today, a brief outline of the agenda. We're going to go through how we got to where we are today with this approach. As we're going to address your frequently asked questions. Thank you to all of you that have been sending questions in advance. And we're going to talk about next steps to move this forward across the UK and beyond. So the speakers today are Karen Perkins. If you can just give us a wave, Karen. Julia Smith. Julia, thank you, Julia. Sarah. And our panelists are Nicola and Jenny. But before we go much further, just a few little bits of housekeeping. So you'll see on your screen, a lot of you have been using it already, the Q&A function. Please could you use that to post your questions to the speakers. If you've got comments, you'll see there's another channel there called the chat. So if you can put your comments or anything else in that chat, please. But if you have specific questions, please put them in the Q&A. And also, if you can upvote the questions on there, because we've got an hour. There's currently 840 of you in this webinar. We know we've got 1,500 people registered. So there's no way we're going to be able to answer all of your questions live. It's wonderful we've got so many people. But please type in your questions, type in your comments, vote on the questions. We'll try and answer as many as we can, but we're recording this event, and because you've all registered, we have your email address. So if you ask a question and we don't have time to answer it, the plan is that we'll be able to answer it afterwards. And likewise, if you can add your comments as we go along. So please, I know you're all filling the Q&A at the moment. Could you move those over to the chat, please, so we can just sort out what are the questions and what are the chat things. So no further ado, I'm going to hand over to Karen now, and we're all going to go off stage and just leave Karen.
Okay, are we good to go then?
We're good to go, Karen.
Good to go. All right, thanks very much, Neil. And big thank you to Neil and Phil for helping support this webinar. I think we're all here because you've all seen this lovely lady, Abigail, in our little film that we made from Morecambe Bay about our project that we've been doing and the impact that it's had on the patients that we have here with learning disabilities who really struggle to access a simple blood test. We've had record response from the Facebook post that came out from our press office late March time. That was picked up by NHS England, which had over 9,000 reactions on it, all positive, I'm glad to say. And our comms team pulled out some common themes here. So you've all been emailing me frantically, and the rest of the team as well, and our inboxes are overflowing, so thank you so much for that. And I'm sorry if we haven't got back to you all, but hopefully this will help just distill a little bit more and answer some of the more detailed questions that you've got. For the sciencey nerds amongst us, I won't be presenting all of the data that we've got from the validation in the laboratory. That's been submitted for publication, and I've just this morning got reviewers' comments back on it. So I'm hoping in the next couple of months that should be out soon. So please hang on for all that data, and don't email me directly for it because I can't get through them all, I'm afraid. But it will be out in the public domain as soon as possible. It's a small set of data, so I'll do a disclaimer there. It's a very simple project that we've done, but it's had this huge impact, and the energy out there has been phenomenal. As Neil says, we've got, I think we're up to 928 people online now. And I told my daughter that we had 1,500 registrants for the webinar, and she put it down to size and said, well, Mum, that's about 50 times less than an average Taylor Swift concert. So we're not that cool, really, yeah. So let's skip on. Next slide. So we've got a poll coming up now. So this is for you guys. We're curious to see who is out there. So I think Phil's going to set the poll running, and we can find out we can all see who's out there. Is that right, Phil? Can you do that for us?
Yeah, poll's running.
There we go. So there's lots of you are from the learning disability nurse population, which is wonderful. A few of my colleague clinical scientists out there, a few charitable organisations, and some carers as well, which is wonderful to see. So we'll just leave that running for a while, and then hopefully you can all see it. You'll all be able to see it on the screen as well when it's finished. So that's just ended. Do we see that on the screen then?
Yeah, results shared.
Cool. So it looks like we've got mostly learning disability nurses there, and paediatricians. So that just tells me that there is a huge clinical need for this kind of thing. And hopefully with the rest of us on the call today, we can piece it together and hopefully make it happen in a wider space. So let's move on. So I'm going to take you through the story so far. It's been a completely multidisciplinary and multi-trust-wide project, this, with a very small team. So Jenny, our learning disability nurse, and our health facilitation coordinator, Julia, who's our GP, and we've worked with Tom Jameson as well at the Loonsdale practice in Kirkby Lonsdale, and I'll show you some of that as we go through. Myself and Andrew Brown in biochemistry, and Joe Kilkenny, our biomedical scientist who did all the groundwork for this in the lab, and Sarah Duffin, who's now our learning disability consultant who works at University of Cumbria, and Nicola, who's new to the team, who's project manager and has helped us with the business case going forwards. So this is all about going from large volumes to small volumes. So instead of routine venipuncture samples, which for most of us is not a problem, but for many people it presents a huge problem, we need to find a different way of doing it. So lots of people have been using finger prick samples, but that's still quite painful. And we've had some of our LD nurses have contacted us and said, we find this really hard. Our patients are finding it painful. They're still fearful of it. It's very difficult to get near them with a needle with the finger. What else? Is there anything else we can do? So just looking around on the internet, we came across the TAP device, which is shown here in this picture, and it's one of several different devices that are on the market for collecting transdermal capillary blood samples. So it works like a kind of like a leech. You stick it on your arm, you press the plunger, it creates a vacuum, and it sucks capillary blood. It pierces the skin in a very shallow manner, and allows the blood just to be collected in a standard pediatric microtainer, shown in this picture here. And for our patients with learning disabilities, this has become a really good alternative option, and is becoming very successful and desirable now as well, we realise. And it's about addressing that 20-year mortality gap. So there's a roadblock in the healthcare pathway for these patients, in that they can't just access a simple blood test. So you can't monitor side effects of drugs, you can't alter doses of things like thyroxine in a Downs patient, you can't look at long-term comorbidities like diabetes, heart disease, and things like that. So these patients are definitely present us with an inequality challenge here, and it addresses the hospital to community challenge with the NHS 10-year plan as well. So we're taking patients away from a phlebotomy clinic, away from a specialist learning disability or paediatric setting, and taking them out into the community so we can do bloods wherever it's right for that patient. So for those of you who haven't seen inside a biochemistry laboratory or a blood sciences lab, this is kind of what it looks like. This is our lab at the Royal Lancaster Infirmary, and we've just recently formed part of the Lancashire South Cumbria Pathology Service, and we're situated within the Morecambe Bay NHS Trust. So usually you get your blood tubes, the standard blood tubes that you see when you go to the phlebotomist to get your blood taken, and these come ready barcoded, and they go on a little pucks like these, and they're barcode scanned. It's all very automated. There's a lot of robotics involved. These analyzers are our immunoanalyzers, so they measure things like cortisol, thyroid hormones, prolactin, some of the other tests that you might be interested in your patients with learning disabilities who are on meds. And then we have some routine chemistry analyzers as well, doing your renal function and your liver function and all those kind of things. So it's very automated, it's very robotic, and all these big analyzers are designed to handle the big adult-sized blood tubes. So that presents the first challenge, because we're working with a much smaller volume of blood in the lab. So there's lots of work that needs to be done in the laboratory first before we can offer this. So a lot of questions have come in saying, can we just buy this and use it? Can we buy the TAP device? Can we buy these capillary sampling devices and use them? You can, but you need to work with your laboratory to make sure that the results you get from a capillary blood sample give you similar results to what you would get on a routine blood test. So we did this in our lab for a restricted number of tests, and I'll show you, or Julia will take you through the request form, and that will give you the list of analytes that we've done in our laboratory. And we did this on GP patients who were just routine general practice patients based in Kirkby Lonsdale at the Loonsdale surgery, and they were just coming in for their routine health checks. And we did this with ethics approval, because we were taking contemporary venipuncture samples with a TAP device sample for that patient. And then they were coming together on the routine transport, so the standard pickup from the Loonsdale surgery to our laboratory at Lancaster. So the pre-analytical time was the same, all those conditions were controlled, and we put them on our routine chemistry and our immunoanalyzers just to see what the results would be, and to compare the results that we got from your routine venipuncture sample with an upper arm capillary device collection. So this is where we come unstuck now. So we've done the groundwork, we've done some validation work, but we've hit a bump in the road because the TAP device is no longer available in the UK. So I don't want you all to log off straight away and think, oh, we can't use it. It's not the end of the world. There are lots of other devices out there that do very similar things and work in a similar fashion. Some of them are awaiting regulatory approval in this country, but it's coming. We're very early in the game with this, and this is a very new technology, a very new way of doing things when it comes to blood tests and blood sampling. If you hook in now, it's a good time, because there's a lot coming down the pipeline. This device, the Tasso, is currently available in the UK, and a lot of you may have come across this before. It's very commonly used in some of the more commercial settings. So all our work's based on the TAP device, but these apply to lots of the other upper arm capillary collection devices. This is a bit of a wordy slide, but this is being recorded, so you can go back to this and have a look through and see what it is. I just tried to gather some of the information that's relevant to these upper arm capillary sampling devices. And there is a paper that's just come out in the Journal of Patient Centricity, which gives you some good information on the benefits of doing capillary sampling and the challenges that you might face in the laboratory with it as well. So as I explained, it's a bit like a leech that sticks on your arm. It's very painless, and you get really good quality samples. So the hemolysis rate in our pilot study, I think we did about 70 patients, and we had one sample that was hemolyzed, and the rest of them have been excellent quality samples. And the pre-analytical stability of them seems really good as well, coming with about an hour's transport time from the GP practice. They've all been received within the lab within 4 to 6 hours, as you would usually do from a GP practice routinely. It's not suitable for certain tests, so you can't use it for everything. It's not a perfect science. There are problems with it, there are failed collections, and it is quite a high rate of not failed collection, but insufficient sample to do all the tests that a clinician might need on that patient. But the bonus with this is, in this patient population, that if you don't get enough the first time, the patient finds it so acceptable that they come back a second time and you can get the next batch of tests done. So it seems to be a win-win in that respect. And the patient experience, Julia will take you through the patient experience a bit later, and Sarah will too. So I'll leave that to them a bit later. So as I say, we're on the edge of change here, which is exciting. And just this February, the NHS launched a pre-market engagement exercise looking for people who could provide transdermal capillary blood sampling solutions. And this was with a view to improve access for underserved populations and enable earlier diagnosis and management for long-term conditions. So that's completely aligned with what we've been doing here at Morecambe Bay with the TAP device, and hopefully with other devices that are coming onto the market soon. The more you think about it, the more patient populations you can think, oh, this would be really useful for them. So hold on to those thoughts, and hopefully you can see how maybe you can work with your team and shape this and bring it to life in your area as well. This market engagement has closed at the end of March, so there should be a report coming out quite soon about this, and it'll be interesting to see what the NHS are finding on a national basis for this. Oh, so we've got another poll here. So if anybody's out there, I don't think we've got so many clinical scientists on the call just now, but if you're running a capillary blood sampling service, where are you doing it? And what kind of device are you using at the moment? So we'll run that poll, please, Phil, if we can.
Yep, they're both live.
Okay, we've got some finger prick users. Ooh, somebody else is using the tap device out there. And somebody's using a different device. No takers for Tasso yet. Okay, we'll give it a few more seconds. There's a few of you answering. Lots of people responding with finger prick. That's interesting. It's the cheapest way of doing it, isn't it? Okay, so we've ended those. Thank you for your input there. So we've got, are you currently running a capillary sampling device and where are you running it? So we've got about 12% of you in general practice, about 60% in the community, which is what you'd expect. This is really applicable to patients out there in the community. They can do it themselves. They can do it as a supervised collection. They can do it where it's convenient for them. And a few people, about 30%, doing it in acute services. So that's really good to know. And a few in private care as well. And then, and which sample device? Most people, as I expected, are using a finger prick sample device because that is the cheapest option and the easiest option. However, it's probably the most painful option out of all the capillary sampling devices. And the rest are kind of split between other upper arm devices, TAP and Tasso. So there's a good spread there. That's really interesting. Thank you for that. Let's go back to this bit. Okay, so that's a little bit about what we've done in the lab. I know I've done it really quickly, but we've only got an hour to get through all of this. So I hope that's answered some of your questions as to what we've done. I'll just give another plug for a paper that's going to come out in the Annals of Clinical Biochemistry in the next issue, which is our recommendations from our national patient-centric testing and sampling group. From a clinical biochemistry perspective for the laboratories as to how you get this up and running and what kind of data you need to get in your lab for UCAS accreditation and all that kind of stuff. So look out for that. And we're launching it at UK MedLab next week if anybody's there. So drop by our workshop and come and get a copy of it. I'll hand over to Sarah. No, Julia now. Thank you.
So really, how did we get this to work in the real world? So the key thing was collaboration between different trusts and different specialities, which we are not really great at in the NHS, but that's the thing that's made the real difference with our project. So how we managed this was in primary care, in our 2 practices, we identified participants from our learning disability register. And we identified those patients who were needle phobic or struggling with venipuncture. And we quickly realized that not everybody on the learning disability register has a problem with venipuncture. Only 20% really would benefit from this method of taking blood samples. So when they were coming for their annual health check, for their learning disability annual health check, we identified those people who needed blood testing. And again, not everybody needs blood testing doing at their annual health check. It is only a minority of patients, but there are certain groups that definitely need it. Screening for thyroid dysfunction in patients with Down syndrome, obviously patients with symptoms who need investigating, patients who may be eligible for the NHS health check, which everybody else is entitled to, and also drug monitoring for patients on psychotropic medication, LFTs, prolactins, that type. This is just a quick slide just to reinforce the importance of the reasonable adjustment digital flag for people with learning disabilities on the electronic patient health record. And it has the codes that we use and the codes that we use for needle phobia that we utilised for this project. And the relatively new thing that's happened is that you don't need to have explicit consent for this. It's now an implied consent for somebody to have a reasonable adjustment digital flag, which will hopefully help with sharing of information between healthcare services. So we've got another poll here, and I was just interested to know what you think the barriers might be for this to be implemented much wider in primary care. So if we could run that poll, that would be great.
Yeah, that's live.
Okay. So yeah, I can see that some of the concerns are about longer appointments. Is this going to take longer? Training of staff, and yeah, the big barrier tends to be working with your local blood science laboratory, because we're not used to doing that. It's a foreign field really for us in primary care. But interesting, yeah, the lack of engagement from patients and carers, that is not an issue. We've certainly found that that's not a barrier. People are very keen for this to be more widely available. Okay. So when we were doing this project, the things that we looked at was accessible information, because obviously this is a brand new way for most people of having a blood sample taken. So we had to develop accessible information leaflets, and we did that with the use of advice from our speech and language, psychologists from the community learning disability team, and there's already a video on YouTube which is very explicit on how to use it. The worry about extended appointments, really that's not the case. We would be offering patients with learning disabilities a double appointment, I would imagine anyway. So this process is not excessively long, especially if the pre-work has already been done. And these processes can actually be done by carers or the patients themselves even in their own home, because there is no sharps risk associated with these devices. They can be and are designed to be disposed of in household waste. And the issue about training, the process itself is very easy. We organised training for staff, but that was within a lunchtime. It was more about the ordering of the devices and that type of thing, rather than the actual process of taking the blood sample. So again, this is a list of the things that we went through and the things that you would have to consider if you were trying to implement this in your own area. And the key thing that we wanted to make sure was that this process was simply going to be integrated into the processes that are already there in primary care. And that's the key thing for it to be successful. So the devices could be ordered from the hospital labs, as with other devices, other blood tests, other blood bottles and supplies. So we tried to integrate that all together and made it routine. The requests for the blood tests themselves that was added to our normal platform, which we use in our area as TQuest on EMIS. So an additional group option was added to that, so it can just be requested as normal, and the labels can be used just as normal. And then the transport for these blood samples was again in the usual manner with the rest of the normal blood tests and samples that are collected in primary care. The main change in the main adaptations that needed to be made were not really in primary care. It was in the hospital labs, and lots of processes that Karen has mentioned would need to be gone through to make this valid in your area. The only additional thing that we asked practices to do when they were taking these blood samples was to fill in an additional form so that they could prioritise which blood tests they required. Because it's just a small sample that's collected, not all the blood tests can be done on the one sample. So it was very useful for people to be able to prioritise which was the most important blood test that they wanted analysing from that blood sample. And this is a list of the blood tests that were available, and that's on the screen there. The major thing to remember is that full blood counts cannot be done with this TAP device. However, there are lots of other ones that are really useful. And we had to specify to people not to add in free text what additional blood tests they wanted, because people were often very keen for that to happen. But we were restricted to just the ones that are in that list there. So I'll hand over to Sarah now, and she's going to talk through about the feedback that we had from patients and their experiences.
Thanks, Julia. Hi, everyone. It's great to have you on the call today. I wanted to talk a little bit about how we engage people with learning disabilities in this process, because as a learning disability nurse myself, it's something that was really important, not just to me, but to the whole team. So it's great that we had this wonderful TAP device, and having tried it myself, I could totally attest to it being pain-free, especially when we compare it to something like the finger prick. But it was really important that we ascertained what were the views of people with learning disabilities. It's fine for me to say I found it pain-free, you know, less anxiety provoking, less stressful, but did people with learning disabilities also share that perspective of the TAP device? So we created some easy read questionnaires that we developed with our speech and language therapist and people with learning disabilities themselves. So they helped us to create these questionnaires, thinking about the things that we might like to know and how that might be best asked. So as you can see, we made that quite a visual. We also developed a separate carer feedback form as well for people who couldn't participate in questionnaires, so that we could get carers as the person who knows that person best, their best guess on how that person felt about the procedure, whether they seem less anxious than normal, etc. So we developed 2 questionnaires. Okay. So this is an analysis of the results of those questionnaires, and you can see it's quite a small number. It's 41 people who were able to participate in giving us their opinion on using the TAP blood device. Some of this really important sort of data to report on here was that some people had never been able to access a blood test, and most people had not been able to access a blood test definitely in the last 12 months, with the majority of people it being longer than that. We tried to explore some of those reasons why. As you can see, there's a significant number of people who were scared of needles, but also a lot of people who are also scared of blood itself, so being able to see the blood. And the great thing about the TAP device is that we can actually sight that on the back of the arm, so it's not visual for the person. They don't actually have to see the blood being collected, so it's out of sight and out of mind. The brilliant report that we have from this data is is number 4. Were you able to give blood using the tap microselect device? And as you can see, the majority of people that we supported were able to do that. And we include in that people who have some really complex presentations. So I was involved in supporting some blood samples for people in their own homes, people who had not traditionally been able to engage in providing a sample, people who needed that extra level of care planning around how we were going to administer the tap and how we were going to support them to be able to use the tap. Okay. And again, the news that was really welcome to us, that most people were happy to use the tap again. They felt it was a good experience, or an okay experience at least. There was just one person reporting it was bad. And most people happily would say use it again and tell their friends to also use that. So that was really significant for us, because not only did we have a blood sample from people sometimes for the first time ever, but also we had the ability to go back and do repeated samples. And again, when we're working with those really small amount that might need more than one test in order to run everything, it was really important that this was something that was going to be usable for people repeatedly and not just as a one-off. So there we go, there's our figures. So yes, people were really happy to use it again. And I think, again, that's where I know there are a lot of learning disability nurses on the call, so I'm kind of going out to you in particular. I think that's where that individualised care planning comes into place, and we were able to be really inventive in the ways that we administered the tap. So, for example, there was no need for people to sit down or be still. We can apply the tap on the go and allow people to move as they wished while the sample was being drawn. So that's okay. It doesn't withstand massive amount of movement. So, for example, one of the failed samples that we had was a young man who was on the go, and he actually knocked the tap device off his arm as he was passing through a doorway. It sort of caught in the doorway and knocked off before it had a chance to draw. But we can allow people to move. We can, make sure that people are engaged. We can get people at the right time of day. So when we're talking about a reasonable adjustment, it really is, it can be administered by the right person, somebody that person trusts, in the right place at a time when somebody's feeling relaxed and happy and confident. So whether that's administering it to somebody while they're in the bath, in a sensory room, we can really think creatively about when's the best point to engage this person in providing a blood test. So that was really important to us. And that overwhelming feedback that we've had from people with learning disabilities and from their carers, that this is actually a real alternative for most people. It's definitely not a catch-all. There are still going to be some people who will struggle to even engage with this process, but we're certainly reaching a lot of people that traditionally we wouldn't have been able to reach. And these are, I'm just going to leave these comments up for a little moment, because the wonderful, people saying it was life-changing for carers, thinking about, we can get these tests going forward, to somebody with learning disabilities saying they were looking forward to the next blood test, which was really lovely. And tell a story of a lady that Julia and I supported with the tap blood test. She was really, really anxious, and she had the tap, and she was like, "Oh, is that it?" And she was then able to provide a second test that she did herself. She self-administered her own tap device, and that was really, a fabulous outcome to see somebody who had not been able to give a blood sample going back to actually providing their own completely independently. It was a fabulous moment. Okay, so I'm just going to hand you back to Julia, because we're going to talk through some of the results that we actually saw from those that very initial pilot group of 20 people. I'll let Julia talk through some of that for you.
So the key question that we need to ask is, so what? So have we actually identified any unrecognised diagnoses or comorbidities from these blood tests that we've been able to do. And we've only been able to analyse from the first 20 patients from our pilot. But even in that small group of just 20 patients, we did identify raised HbA1cs, giving people an increased risk of diabetes, hypercholesterolemia, and abnormal thyroid function tests. So those patients then had the appropriate interventions provided for them, or their medication changed. But it's not just about finding abnormal results. What we didn't fully appreciate was that the actual benefit of having a normal blood result can be very reassuring for patients and carers. So this is a patient of ours who is 39. She has congenital heart disease, obviously on our learning disability register, but with severe needle phobia due to previous attempts at venipuncture. And the family were very concerned that she may be developing, or she may have type 2 diabetes from her sort of very high BMI level. And they were very keen to have that tested. So we were able to perform a HbA1c blood test using the TAP device, and that came back as normal. However, her sister there, her carer, said, this was a direct quote from her, that she felt that this process was actually life-changing, because in the future she felt that there was much less of a concern when she was going to need some blood tests doing, or some sort of hospital intervention. So I think we're now moving on to Karen.
Thank you. So yeah, there's loads of good questions coming in. I'm trying to answer a few as we're all speaking here. This last bit, there's quite a few asking about business cases and funding. So the initial pilot that we did with our 20 patients, we did, and our validation project was done. Our validation project was done with a research innovation grant from UK lab, LabMed, whatever we call it now. And the pilot study was done with Morecambe charitable funds from the trust. And since then, Nicola's with us on the panel today. She's new to the team, but she's a project manager and sits within our ICB. So we have recently had approved a business case for the next year to run this project. So it all depends on how funding is streamed through your trust. Different places do, different trusts do it in different ways. Sometimes the budget for blood bottles sits within pathology. Sometimes it sits within GP land or wherever. So it's up to you to go away and decide how you want to formulate that. But what we can do here, hopefully, is give you what we put as our benefits of realization within our business case. And this, I think, really helps lever it. While it's very difficult to find the cost benefit of this and the cost savings of this, because every patient is very different. So the cost of months and weeks of desensitization, the cost of general and risk of general anesthetic, it's very hard to put a number against those for a population, because every patient is different. But what we can do is show how the benefits are realized in this patient group. And these 4 sections here kind of spoke quite loudly. And definitely now, because we've got the NHS hospital to community and more preventative approach to medicine, it aligns very strongly with that philosophy now. Also, I think you'll find there's a growing wave of knowledge and a growing wave of enthusiasm for doing more patient-centric sampling. And if you want to know any more about that, I'm going to do a shameless plug for Neil's website, the PCSIG website, which you're on right now. And the webinar will be listed on later, so you can go back and watch it again and again if you really like listening to us like that. That's fine. but he's got loads of information about all sorts of different patient-centric sampling projects, populations, devices, information, and from patient perspectives as well. So the patient voice in this is what's right for a patient. We're very good in the NHS about force-fitting a system that already exists on our patient population. And while we've got technology coming down the line, we need to grab onto it and talk with our patients and with our clinicians and with our laboratories to try and mold it and shape it and see how we can best fit it into our procedure. So I'll leave you with those salient points in our business case that I think finally got it through. I did have to put my ugly mug on camera to get it sorted at the end. I think maybe they gave us the money so I wouldn't start going on camera left, right and centre, but it definitely is worth working. And I think because one trust has done it now, and there's a few other trusts out there that are having a go at this as well, the same as us with a similar protocol, the momentum is growing and the knowledge and the awareness of this is growing. So I think that's it for now. We'll take some questions. Hopefully we've got some time. But we always say if we can't make it work for people with learning disabilities, then we can't make it work for anybody, or we can make it work for all those people who need it. And one of the great comments that I saw on I think it was the NHS England Facebook post, maybe one of you's on the call right now, but somebody said, this is what reasonable adjustments in the NHS should look like. And we all in this team really believe in that. It's really exciting to be able to have such an impact on a small population, but a very significant population. So thanks a lot very much to Neil and Phil. As I said at the beginning, they've helped support us just get the communication of this out there, and especially Janine at Gorgeous Media, who helped us make that lovely film about Abigail's story with Heather, Abby's mum, who has been an absolute soldier throughout all of this and let us share her wonderful poem that she wrote about her experiences with Abby and her blood tests. The comms team who have helped put the press release together and get us to this stage. And of course, the Bay Hospitals charity, we wouldn't have been able to do this without the funding they gave us initially. And Your BioHealth, which is the company that makes the TAP devices, who a lot of you are asking, why is it not available anymore? They've been taken over by a company in America called Hims & Hers, and they've removed the TAP MicroSelect from the market and are relaunching as TAP 3, which will be exclusively available to Hims & Hers at the moment. So I'm hoping if there's anybody from Hims & Hers on this call listening in, that they will listen to the voice of people here and the desire and the clinical need for something like this in this country now. It would be great to have it back on the market here. I think that's it for now, is it? Are we at the end?
So yeah, if we can bring, thank you, Karen. If we can bring Julia, Sarah, Nicola and Jenny all back on screen. And, we've got an opportunity, this has been absolutely phenomenal. I can see there's over 1,000 of you online, which is just amazing. It shows the appetite for this, and hopefully this event will help you. It is being recorded. It will be available through our website in the next few days, but we've got an opportunity now to answer a few questions. Maybe one of the ones that I saw that's come up many times, it may not have been the most popular single question, but it's been asked many times in many different ways, is around about the cost of this. And just if anyone is able to comment a little bit more specifically around that at all.
Yeah, the device itself, the TAP device, was about, I think when we started, it was about £20 a pop, which was a lot. It's now down to about £11 a pop, and I suspect these types of devices will come down to about £5. So you're balancing that against not being able to do any blood tests in a patient and the risk of that, the cost of general anaesthetic and desensitization work, and maybe some of the other guys can answer to the cost of all those other things that go on with this patient group. But yeah, it's a cost, but it's worth doing in my opinion.
Yeah, I'd agree with that really, Karen. I think the cost of repeated blood test appointments, possibly in primary care, the use of learning disability nurses to do all that desensitization, which isn't, let's be honest, always successful, and even to this point of requiring some sort of general anaesthetic or sedation for venipuncture, obviously that outweighs the cost of the actual device. And it's important to remember that it's not for everybody with learning disabilities who needs a blood test. The majority of people will be fine with venipuncture, and that's the ideal, because you can do so many more blood tests on a venipuncture sample. But this is an alternative.
Thank you, Julia. Thank you, Karen. I'm going to field one of the other questions here. A question that came from Elizabeth, but 19 people have said they want this question to be asked. How long does the device have to be on the arm for one sample? Can you change the bottle to collect the next sample, or do you need to reattach the device?
No, it's at the moment it's one device per sample, so you cannot change the tube. However, some of the other devices coming onto the market and the redesigned tap device, you can change the tube, which is great, and you could get more than one sample. Most manufacturers say it's about 5 minutes on the arm, no more than 5 minutes. You start to get blood clotting, and I'll answer another popular question while I'm speaking about this. The blood flow coming from the capillaries into the device takes a period of time, and blood starts to clot as soon as you pierce the skin. Your natural reaction is to clot and stop bleeding. So the blood starts to clot, so it has to travel into that tube. And if you've got clotted blood, you can't do a full blood count. So that's one of the reasons we can't offer a full blood count on this. The other one you may have noticed on that request form, we don't offer potassium, and that's not because of hemolysis, it's because we see a much a positive bias on those results. So a false, well, not a falsely elevated, it looks maybe like we might need a different reference range for potassium, but we don't have the time and resources to provide that different reference range. So we're not offering potassium at this stage on these types of devices, but that will come. I think that will come.
Thank you, Karen. Another popular question from Louise is, have the tap devices you're using been verified clinically, i.e. are the results from capillary blood validated against results from venous blood samples?
Yeah, that was the whole point of the pilot project. Sorry, I rushed through a lot of that, but it's on the slide where we took contemporary venipuncture samples with the capillary samples from just general GP patients coming in for a wellness check or their routine health checks with ethical approval, because we were taking an additional blood sample, and those samples were treated, once we collected the samples, they were treated exactly the same from coming from the practice, from the patient, arriving in the laboratory, and the processing within the laboratory as well. So yes, there are concordant results and satisfactory within our bias limits. Yeah.
Thank you, Karen. Alice has a question. Does there need to be a lab on the same site as the testing is being done in terms of timescale from sampling to analysis? The trust I work in send our bloods to the local acute trust, much like GP practices do, so there is often a delay.
I mean, I can answer that from a GP point of view. We send our samples to our local hospital 3 to 4 hours. Is that right, Karen? For the transport, and that doesn't seem to be a problem.
Yeah, we ran the pilot study out at Kirkby Lonsdale, which is about an hour door to door. So, and the samples, the clinics for collecting the samples were run first thing in the morning. So it was between 4 and 6 hours before they actually arrived in the lab with those contemporary venipuncture samples. So we've done that kind of, it's a rough pre-analytical assessment, but yeah, you need to work with your laboratories really carefully to make sure they're happy with the sample stability and the concordant results with venipuncture.
Thank you, Karen and Julia. Just a specific analyte being asked about by Jonathan, but a lot of people are interested in this. Has it ever been used for collection of clozapine blood?
There's quite a few papers coming out looking at therapeutic drug monitoring using upper arm transdermal capillary sampling devices. And I urge you to have a scope through the literature or take a look at our recent publication in Journal of Patient Centricity. She says, shamelessly plugging it again. There's quite a bit of information in there. And yeah, it's horses for courses. If you want to do a trial looking at that, it's not even a trial, it's a service improvement project essentially, isn't it? Because these are already on the market. There's a lot of data out there on them. You need to get them and use them. So yeah, you use it for whatever you think would be useful. There's a lot of data out there.
Thank you, Karen. Question from Rachel, popular question. Does it have to be used on the arm?
Sarah, you could possibly answer that one, could you?
Is Sarah?
I certainly can. Yeah, we've worked mostly with it on the arm because that's just been the easiest, most accessible place, especially when you're thinking about heating the area beforehand. But we've also used it on lower back and on the thigh for one person who wouldn't tolerate the arm. So there is the option to move it around wherever you've got good capillary flow, I would say. Is that fair enough, Karen?
Yeah, it's anywhere where you've got low density of nerve endings. So the back of your upper arm, a nice juicy baby thigh, I think is a good target if you're thinking about pediatrics. And we have one patient who the lower back works really well. The transdermal thickness, so the thickness of your skin varies on the upper arm. And there are a couple of patients we really struggled to get a sample from. And I think it was because of that. And we tried the lower back and it worked first time. So yeah.
Part of the process, I don't know whether it's clear for everybody that you do need to warm the area prior to attaching the device, and it comes with a preheated sort of pad that you then apply to the arm, and that warms it and it dilates the blood vessels. So that's part of the process, and that's makes it a little bit longer because the ideal time to do that is between 3 and 4 minutes. And patients need to be able to tolerate that on the arm. That's another issue with them. But that allows to have rapid blood flow. And then if there's rapid blood flow, it doesn't need to stay attached for as long, because as soon as it reaches the level on the tube, you can then remove it.
Yeah, I think the other thing we've done is been really creative in how we help people get warmed up and hydrated, and sort of, you know, we had one gentleman who, because of his autism and sensory differences, he likes to wear like the tight skins, you know, the slight compression tops, and we're able to just slip a heat pad down his top, and that held it in place, so he didn't need anybody touching him or bothering him while he warmed up. He was able to keep that in for a good 5 minutes before we took the sample. So thinking again, learning disability nurses on the call, being creative in how you make this happen for people. That individualised care planning so important for more complex people, isn't it?
I think as well, Sarah, just to add, sorry, I keep freezing, so hopefully you can hear me okay. But one gentleman also had it done in the bath. He couldn't tolerate the heat pad, but got lovely and warm in the bath, and that was a real success for him as well. So like Sarah said, just thinking outside the box a little bit.
That's wonderful comments. I think we'll do one more question and then we'll move on to next step. So I think you've got a slide about that, haven't you, Karen? So just do this one last question, which just disappeared from my screen. Where's it gone? Oh yeah, if someone needs very regular blood tests, are there any known issues with skin tissue damage to using the device in the same place?
Depends what you mean by regular. I can't think of a blood test you'd need more than, well, once every couple of weeks or so, out in the community. There's no evidence that I know of where it leads to long-term skin damage, but again, we're very early on in the process with this.
I think you'd naturally rotate the sites anyway, wouldn't you, Karen?
Yeah,
you wouldn't use
and you've got various options, as we've just talked about: lower back, thigh, either thigh, either arm. So you
and when you remove the device, it does leave a tiny little ring of where it's been attached, a bit like a bruise, but very minor. But that fades within a couple of days.
Okay. So Karen, I think you had a slide about next steps, yeah?
Yeah, so this is our call to action. So we've been here for an hour. There's how many of you on the call now? There's like millions of you. We've beaten Taylor Swift for sure. There's 1,052. So Taylor Swift, go eat that. You know, we rock. But this is our call to action. So we've done a very small project with very limited data. It's not a perfect science. I'm not the world's best clinical scientist. I've got a great team around me, and there's a huge clinical need for it from our laboratory. And we've managed to make something kind of roughly work here. And it needs somebody bigger and cleverer and more important than me and the team here to take this forward nationally. So this is our call to action. There's lots of you out there. Our comms team at Morecambe Bay here pulled out some common themes from the Facebook post. Some of you asked about national NHS funding, and that's a question I've been asking myself as well, and asking NHS England about this. We know the political situation with NHS England has changed dramatically in the past month, so they're in a bit of a turmoil at the moment, but I think the plans for the coming year will hopefully include something like this, and I'll keep fighting as hard as I can for that. Can we roll it out to all trusts? We're going to start looking at rolling it out across our ICB, and we've got 4 different laboratories across our ICB, and we've got 3 different manufacturers of laboratory equipment, so we've got a big challenge there. And there's other groups that would be really relevant too. People have tagged their MPs, their ICBs, and their NHS organisations to say, can we have this, can we have this? But as you can see, there's lots of steps you need to go through, and there's different members of the team you need to integrate. And we need somebody, maybe nationally, maybe there's a charitable organisation out there, an NGO that would be good at collating voices and process and building this into something much bigger across the country for this patient group where it's so badly needed. So we've had comments like raising the issue with the local trust, asking your LD nurses and reasonable adjustment teams, and all the very sensible things that we can do. And hopefully it'll build momentum around the country, and we'll find devices coming onto the market that we can use. So it's all very well having one device, but it's not, one device doesn't fit all. There's other devices out there, and we should look at all of them as well, because this is a new developing science. So I ask if anybody's out there who are willing to take the reins of this nationally, please either contact Neil or put something in the chat just now, and we can talk about how we join up all these dots. That would be really great. So that's our call for action and call for help building the bigger picture. And there's an email here, contact@pcsig.org, which is Neil's website, PCSIG. So I shall leave it at that. Thanks so much, everybody, for all your interest. It's just been overwhelming.
No, thank you for that, Karen. And yeah, we'd very much like people who want to be involved in helping to take this to the next step, both locally and potentially internationally, beyond the UK as well. PCSIG are an international organisation, and obviously there's people around the world that can benefit from this technology. So if you're interested in helping to take the lead on this, or being involved in what we can do to help roll this out nationally and internationally, please drop a line to contact@pcsig.org. I'm just going to go on to the next slide, which just the Patient-Centric Sampling Interest Group is a not-for-profit group. We're international, but we're registered here in the UK. And we exist for basically educating people about these technologies and helping them to be adopted in different places around the world for different patient groups and different applications. If you're interested in our website, the QR code on the left-hand side will take you to our website. Also on LinkedIn, which is the kind of professional Facebook, we have a community on there. You're more than welcome to join and learn about and contribute to all our activities that we have going. And the QR code on the right-hand side there will take you to our LinkedIn group, where you can learn a lot more about us as well and get involved. But as we say, this is the first part of this was very much education about what Karen and the team, Julia, Sarah, Nicola and Jenny have done, and sharing that with you. But we're very much encouraging we need to go further. But as Karen said, we're not in a position to take the lead on this, but hopefully there's people out there that can. Hopefully there's people out there that maybe your bio and Hims and Hers will still enable this TAP device to be available in the UK, because they'll be able to see the strength of feeling here with over 1,000 people excited and interested. You've all had lots of comments, you've had lots of questions. We will be compiling all of those, and we have all of your email addresses, and we're going to be able to write to you and contact you. And obviously we have a lot of content with all the webinars featuring other groups and other clinical conditions that you might be interested in taking a look at on our website. Coming up, we've got Chiara talking about remote monitoring of anti-seizure medications. in epilepsy patients. And we've got Tim coming up in July talking about some of the UK recommendations for the labs. So we always have about one webinar a month. They're not as well attended as this, but everyone's welcome to attend. And I really need to thank our partners and sponsors who help fund what we do, and we wouldn't have been able to bring you this event today. So please, if you're interested in taking part, contact us. We will be compiling I see there's hundreds of questions and there's hundreds of chats. It's going to take us a little bit of time to get to it all, but thank you so much. This has been absolutely phenomenal. Thank you to Karen, Julia, Sarah, Nicola, and Jenny for sharing their experiences. It's been brilliant. Thank you to Phil for help for behind the scenes, making this all work seamlessly today. And thank you all for attending and listening and hopefully learning and putting pressure on your own local environment for this to happen for this patient group, but also we know there's many other patient groups that this technology will benefit as well. So we know the NHS are interested in this, and hopefully we're hearing good things about the NHS app and some care pathways being enabled with these technologies in the coming months and years. So, but if we can all put pressure on it, all makes it happen. So thank you, everyone. And that's the end of the hour. So we'll end the webinar. It'll be available on our website in the next few days. Thank you all.